We'll be breaking down all major concepts covered on the exam.
Exactly.
So imagine taking a really deep breath right now.
Just a big inhale.
Right. With that single inhalation, you likely just pulled dozens or maybe even hundreds of these microscopic fungal spores deep down into your airways.
Oh, yeah, easily.
And we do this every single day, right?
Yeah.
For a healthy person, it's totally complete non-event. But for a specific subset of patients that you'll encounter on the wards and absolutely on your board exams, that single breath is basically the starting gun for a catastrophic, life-threatening infection.
Yeah. The pathogen we are talking about today exploits vulnerabilities in the human body in vastly different ways. It depends entirely on the structural and immune landscape it lands in.
Right.
You really cannot memorize this as just one disease. I mean, you have to understand the specific host to predict how the pathology will unfold.
So true. Oh, and I'm Harvey.
And I'm Donna.
And we are MCCQE reviewers. Our mission here is strictly dedicated to helping Canadian medical students feel way more comfortable with the exam review process.
Yeah, we really want you to walk into test day with confidence, knowing you've mastered the highest yield material.
Absolutely.
Yeah.
But before we go any further, we do need to explicitly acknowledge that this deep dive teaches directly from reliable StatPearls articles.
Yes, very important. And it is crucial to remember that this audio is for medical education only, okay? It is not medical advice.
Right. Any clinical decisions out there in the real world must involve a qualified healthcare provider.
Exactly.
So, getting into it, our focus today falls squarely under the infectious diseases umbrella, specifically Aspergillosis.
Yeah, Aspergillosis.
You really should think of Aspergillus as the ultimate opportunistic chameleon. The exam is going to present this one pathogen in 3 completely different ways, depending almost entirely on just one factor.
And that factor is the immune and structural status of the patient in your clinical vignette. The clinical implications here, they range from a completely non-urgent scenario, where the standard of care is simply to wash and wait,
which is wild.
It is, all the way to a highly invasive process with a mortality rate approaching, 100% if it isn't recognized and treated immediately.
Literally 100%. So before we get into those 2 extreme clinical ends, we need to establish the baseline, right? We need to understand the pathogen itself and the pathophysiology of how a normal, competent immune system actually handles it.
Because that knowledge really sets up the mechanisms for when things inevitably go wrong.
Right. So we are dealing with fungi from the Aspergillus genus.
Yeah, and there are over 24 species capable of causing human disease. But on the exam, Aspergillus fumigatus is, by far, the most common cause of infection.
Right. Fumigatus is the big one.
Definitely. Though you will also see Aspergillus terreus, Aspergillus flavus, and Aspergillus niger showing up in questions, too.
And in the enamorment, these are just ubiquitous molds, right?
Exactly. They break down dead organic material in soil, compost, dust, you name it, and they reproduce asexually by releasing these tiny spores.
The conidia.
Right, known as conidia, into the air.
And those conidia are exactly what we inhale.
Yeah.
So let's look at the microbiology high yields right away. When a question stem provides a pathology report from a biopsy, students are conditioned to just scan for buzzwords.
As they should be.
Yeah. So the stains to look for are karyotic acid Schiff, or PAS, which basically stains the fungal carbohydrates, this bright magenta color.
Right, magenta.
And the Gamori methenamine silver stain, or GMS, which stains them black.
Yeah, and when you see those stains, the absolute classic histopathology description for Aspergillus is, you'll see septate hyphae with acute angle branching.
Septate hyphae with acute angle branching.
Yes. Usually that angle is described as being about 45 degrees, and this is a critical distinction to make on the exam. You absolutely must differentiate this from mucormycosis.
Right, because mucor is different.
Exactly. Mucormycosis presents with non-septate hyphae that branch at wide 90-degree right angles.
Okay, so Aspergillus is septate hyphae with acute angle 45-degree branching, meaning the fungal filaments have internal cross walls, or septa, dividing the cells, and they branch like a sharply angled letter V.
You got it.
Now, the source material notes these spores are present in concentrations of 1 to 100 per cubic meter outdoors and indoors.
Yeah, they are literally everywhere.
So if it's everywhere, if we are constantly inhaling these conidia, my immediate question is, why aren't the airways of a healthy person entirely colonized by mold? Why aren't you and I infected right now?
Right. Well, the primary reason involves our innate immune system. When an immunocompetent person inhales those conidia, pulmonary macrophages and respiratory epithelial cells act as the first line of defense.
Okay.
The spores settle in the alveoli, and at normal human body temperature, those inhaled spores begin to swell, and they try to germinate into invasive hyphae.
But the body recognizes that germination process, right?
Yeah. Exactly. As the conidia swell, they expose specific proteins and polysaccharides that are usually hidden in their cell walls, like beta-1,3-glucan.
Right, beta-glucan. And those exposed antigens trigger the release of pro-inflammatory cytokines, which basically summons the heavy artillery.
Yes, the neutrophils.
Neutrophils.
Neutrophils are the definitive line of defense against Aspergillus. They swarm the newly formed hyphae and execute this localized chemical attack.
The respiratory burst.
Exactly. They undergo a respiratory burst using the enzyme NADPH oxidase to generate massive amounts of reactive oxygen species.
Like superoxide and hydrogen peroxide.
Yes, and this physically degrades the fungal cell wall and basically neutralizes the threat before it can actually invade the tissue.
And that mechanism is exactly why a patient's neutrophil count is the single most important metric when evaluating their risk for invasive fungal infections, right?
Absolutely.
Because if a patient lacks neutrophils, say, I don't know, perhaps they are undergoing intensive induction chemotherapy for leukemia, or maybe they recently had a hematopoietic stem cell transplant, so their bone marrow is just completely suppressed.
Yeah, in those cases, they've lost the ability to mount that respiratory burst. The fungus is just completely free to germinate and spread unchecked.
Wow. And that underlying pathophysiology transitions us directly to the most dangerous presentation, which is invasive pulmonary aspergillosis, or IPA.
Right, IPA.
We are moving from a completely healthy immune system to one that is severely depleted.
Yes. This typically involves patients with hematologic malignancies, profound and prolonged neutropenia, or transplant recipients on, really heavy anti-rejection medications.
And the sources also highlight a rising incidence in patients with severe viral infections, too.
Oh, yes, specifically severe influenza or COVID-19 pneumonias.
Really? Just from a virus?
Yeah, the extensive viral damage to the respiratory epithelium combined with the extreme immune dysregulation and, honestly, the systemic corticosteroids we use to treat those viral infections, it creates a perfect storm for fungal invasion, even without traditional neutropenia.
That makes a lot of sense. So the defining pathophysiological hallmark of invasive pulmonary aspergillosis is angioinvasion, right?
Yes, angioinvasion is the key word. The growing fungal hyphae do not merely sit within the alveolar space. They aggressively invade the walls of the pulmonary blood vessels.
Oh, wow.
And when the fungus breaches the endothelium, it triggers localized thrombosis, so the blood vessel just clots off completely.
And that thrombosis cuts off the blood supply to the downstream lung tissue, leading to, ischemic infarction and tissue necrosis.
Exact.
So the fungus is essentially destroying the lung architecture by starving it of blood.
That's exactly what's happening. And because it has access to the bloodstream now, it can spread hematogenously to distant sites.
Right.
Most notably causing lesions in the brain, the skin, or even the heart valves.
And that mechanism of angioinvasion beautifully explains the classic radiographic findings tested on the exam.
It really does. The most famous one is the CT halo sign.
Right, the halo sign. So when you look at the chest CT of a severely neutropenic patient with IPA, you're going to see a dense central macronodule.
And that nodule represents the actual fungal mass and the infarcted lung tissue itself.
And then surrounding that dense central nodule is a hazy ring of ground glass opacity.
Right.
I always think of it kind of like a crime scene. Like the central nodule is the fungal culprit, and the ground glass halo is the collateral damage.
That's a great way to picture it. Because the fungus invaded and thrombosed those local blood vessels, blood and hemorrhagic fluid literally leak out into the surrounding alveoli. And that perimeter of alveolar hemorrhage is what shows up as the hazy halo on the CT scan.
That makes perfect sense. Now, there is another major radiographic finding associated with IPA, which is the air crescent sign.
Yes, the air crescent sign. This presents as a crescent-shaped pocket of air, basically wrapping around that central nodule. And the timing of the sign is highly testable because it relates directly back to the neutrophils we talked about.
Wait, so the sources explicitly state the air crescent sign appears much later in the disease course, well after the initial halo sign. But why?
Right. So during the acute phase of profound neutropenia, the tissue infarcts and forms that solid necrotic nodule.
Okay.
But the air crescent sign actually appears after the patient's bone marrow
Oh,
recovers.
so when their absolute neutrophil count begins to rise again.
Exactly. The returning neutrophils finally infiltrate the lung and begin actually doing their job. They enzymatically break down and clear away the dead necrotic tissue at the periphery of that infarcted lesion.
Wow. So as that dead tissue is resorbed and coughed up, it just leaves behind an empty crescent-shaped space filled with air.
Yep. So seeing an air crescent on a follow-up CT is paradoxically a radiographic signal that the patient's immune system is waking back up.
It's actively clearing the infarction. That's fascinating.
It really is.
Okay, let's move to diagnosis. Let's say you have a profoundly neutropenic patient presenting with a fever that just doesn't respond to broad-spectrum antibiotics, plus pleuritic chest pain and hemoptysis. You get the CT showing the halo sign. You perform a bronchoscopy to obtain a bronchoalveolar lavage, or BAL. We need to discuss the primary biomarker here, galactomannan.
Ah, yes, galactomannan. So this is a polysaccharide component of the Aspergillus cell wall. As the fungus actively grows and invades tissue, it basically sheds this polysaccharide into the surrounding tissue and bloodstream.
So we can detect it in both serum and BAL fluid.
Exactly. But the diagnostic utility depends entirely on the specific patient population.
Right. The sources said that in patients with hematologic malignancies and stem cell transplants, serum galactomannan testing has a sensitivity of around 70%.
Which is pretty good. However, in solid organ transplant recipients, that sensitivity plummets to around 20%.
20%, that's terribly low.
Right, making a negative serum test highly unreliable in that specific group.
Wow. And the exam writers love to test the causes of false positive galactomannan tests, don't they?
Oh, absolutely. The assay isn't perfectly specific to Aspergillus in humans. There are several, honestly, surprising clinical scenarios that will trigger a positive result without any invasive fungal infection actually present.
Like intravenous amoxicillin and piperacillin tazobactam formulations, those are classic culprits.
Yes. And the reason for this is fascinating. These beta-lactam antibiotics are manufactured using penicillium molds.
Right.
And penicillium and Aspergillus are closely related fungi. They share similar cell wall antigens, including galactomannan. So administering those antibiotics basically pumps cross-reacting fungal antigens directly into the patient's bloodstream.
That's a huge trap.
Yeah.
Using certain intravenous crystalloid solutions like plasmolite when collecting the BAL sample can also contaminate the reading, right? Since the manufacturing process for those fluids can introduce trace amounts of the antigen.
Yep, that's another one. And even more surprisingly, eating certain foods, specifically ice pops or certain pastas, has actually been reported to cause false positive serum galactomannan levels, particularly in pediatric patients.
Wait, eating ice pops? Are you serious? That sounds bizarre.
I know, it does, until you look at the industrial food manufacturing process. Many commercial ice pops and candies use artificial flavorings, stabilizers, or citric acid that are produced in massive vats via industrial fungal fermentation.
Oh, wow.
Yeah, so trace amounts of galactomannan from the manufacturing mold survive the processing, and they are absorbed through the patient's gut, which spikes their serum biomarker levels.
Okay, that is a wild fact to keep in mind. Moving on to the management of invasive disease. The absolute priority is decreasing the patient's immunosuppression if clinically feasible, right?
Yes, lowering corticosteroid doses or waiting for neutrophil recovery. And then the pharmacological drug of choice is voriconazole.
Right, voriconazole. It's a potent triazole antifungal, but it requires really strict therapeutic drug monitoring.
Because the pharmacokinetics of voriconazole are notoriously nonlinear, meaning a small dose increase can lead to a massive spike in serum concentration, which obviously increases the risk of neurotoxicity and visual disturbances.
So you must check voriconazole trough levels, typically 4 to 7 days into therapy, to ensure they are in the therapeutic window. And you have to recheck them anytime a potentially interacting medication is altered.
Exactly. There are also intrinsic resistance patterns that are heavily tested on the exam. Aspergillus terreus is intrinsically resistant to amphotericin B.
Good to know.
And Aspergillus calidostis is intrinsically resistant to the azole class, including voriconazole.
So if a biopsy or culture identifies those specific species, you have to alter your empiric therapy immediately.
Absolutely.
Speaking of biopsies, the sources highlight a critical procedural point. Like if an interventional radiologist or surgeon biopsies a suspected lung lesion, Sending the entire specimen to pathology submerged in formalin is considered a fatal error for patient care. Why is that?
Right, so formalin is a powerful chemical fixative. It works by cross-linking proteins, which beautifully preserves the tissue architecture for the microscope, but it completely sterilizes and kills all living microorganisms in the sample.
Oh, so it kills the fungus.
Yes. So if the lab only receives a formalin-fixed specimen, the pathologist will, they'll observe the septate hyphae with acute angle branching and confirm the presence of a mold.
But because the fungus is dead, the microbiology lab cannot grow it in culture.
Exactly. You permanently lose the ability to perform species identification and antifungal susceptibility testing. So if that patient has an intrinsically resistant strain like Tirius, you will be flying blind with your drug choice.
That's terrifying. So you really must ensure a piece of fresh tissue is sent in a sterile container with saline specifically for microbiology culture.
Exactly right.
Okay, let's transition away from patients with broken immune systems. The second major category involves patients who have totally intact immune systems, but severely broken lung architecture.
Right. This brings us to chronic pulmonary aspergillosis and the aspergilloma.
In this clinical scenario, the patient's neutrophils are functioning perfectly. The pathogen cannot cause angioinvasion because the immune system just won't allow it.
Yeah, the root cause here is colonization in the setting of pre-existing structural lung disease.
A helpful analogy I like is a squatter moving into an abandoned house.
Oh, I like that.
The abandoned house is a pre-existing cavity in the lung parenchyma. This cavity could be the result of a previous Mycobacterium tuberculosis infection from, a decade ago, or severe bullous emphysema from COPD, or even advanced sarcoidosis.
Right, so the inhaled Aspergillus canidia basically bypass the normal mucociliary clearance, land inside this cavernous empty space, and they simply set up camp.
And they are somewhat shielded from the immune system while sitting inside that cavity.
Yep. And over time, a massive sphere begins to form. This is the aspergilloma, commonly referred to as a fungus ball.
Fungus ball, right.
It is a tightly packed, intertwined mass of fungal hyphae, fibrin, mucus, and cellular debris just rolling around inside that old lung cavity.
And the classic presenting symptom for an aspergilloma is hemoptysis, coughing up blood.
Very common.
A common exam question will probe the exact mechanism of this bleeding, like why are they bleeding? The lung tissue immediately surrounding these chronic cavities is highly vascularized, often supported by hypertrophied bronchial arteries.
And those bronchial arteries are part of the systemic circulation, meaning they are under high systemic blood pressure.
Right, so as the fungal mass grows and shifts within the cavity, the constant friction physically encroaches upon and erodes into those high-pressure bronchial vessels.
Furthermore, the chronic localized inflammation makes the vessel walls extremely friable and prone to rupturing. So hemoptysis occurs in a significant percentage of patients and can range from mild blood-streaked sputum all the way to massive life-threatening hemorrhage.
Wow. So managing this squatter requires careful clinical judgment.
Yeah.
And the initial instinct might be to just prescribe a long course of systemic antifungals.
You'd think so, but no. If a patient is found to have a small aspergilloma incidentally on a scan, they're completely asymptomatic, and the cavity is not precariously close to major blood vessels, the standard of care is actually just watchful waiting.
Really? Just watch
Yeah,
this.
because the systemic antifungals have really poor penetration into that avascular cavity anyway. You just monitor the patient with serial imaging every 6 to 24 months.
But the management algorithm changes entirely if the patient develops hemoptysis.
Oh, completely. You must intervene to stop the bleeding then. Medical management might include tranexamic acid to promote clotting. And for severe bleeding, interventional radiology is consulted to perform a bronchial artery embolization, where they thread a catheter into the bleeding vessel and deploy coils or particles to physically plug the leak.
And the definitive cure, assuming the patient has adequate baseline lung function to actually tolerate it, is a surgical resection of the cavity in the fungus ball by a thoracic surgeon.
Yes. And alongside those procedural interventions for symptomatic patients, you prescribe a minimum of 6 months of oral antifungal therapy, typically with itraconazole or voriconazole, just to prevent local recurrence.
Got it. Okay, so we have covered immune deficiency leading to invasive disease and structural deficiency leading to an aspergilloma. The third and final presentation of Aspergillus on the exam represents the exact opposite of immune deficiency.
Right. It is driven by a massive overactive immune response. This is allergic bronchopulmonary aspergillosis, or ABPA.
The patient demographic for ABPA is incredibly specific. You will almost exclusively see this diagnosis in patients with underlying asthma or cystic fibrosis.
Yes. In this case, the lung architecture isn't cavitary and the immune system isn't depleted. Instead, it's just dangerously hypersensitive.
So when a patient with asthma or CF inhales A. fumigatus spores, their body basically fails to mount a standard quiet clearance via macrophages.
Instead, the fungal antigens trigger a severe allergic reaction. The immune system processes the antigens and activates Th2-CD4 helper T cells.
And that Th2 pathway is the classic driver of allergic inflammation, right?
Exactly. These T cells release interleukins, specifically IL-4 and IL-5. IL-4 drives B cells to undergo class switching and produce massive quantities of IgE antibodies directed specifically against the fungus.
And IL-5.
IL-5 is the primary cytokine responsible for recruiting and activating eosinophils. So the body just panics and treats the environmental mold spore like a severe, overwhelming allergen.
And the clinical presentation reflects that hyperactive Th2 response. Patients experience refractory asthma exacerbations, progressive dyspnea, and wheezing. But the most distinguishing symptom in a clinical vignette is the production of large amounts of thick, brownish sputum plugs.
Right, those brown plugs are essentially casts of the airways, formed by the hypersecretion of mucus combined with massive amounts of dead eosinophils, cellular debris, and trapped fungal elements.
Gross.
It is. But this severe mucoid impaction blocks the airways and leads directly to the radiographic findings of ABPA.
Which are so testable. On chest imaging, you will see central airway dilation, or bronchiectasis, specifically caused by this mucus. The classic radiologic descriptors are branching finger-in-glove opacities.
Finger-in-glove, exactly. The bronchi are literally stuffed tight with dense mucus so it resembles fingers inside a glove on the X-ray. You might also see descriptions of transient toothpaste shadows representing that thick mucoid impaction.
Now, diagnosing ABPA requires checking off very specific criteria, right? The patient must have the predisposing condition of asthma or cystic fibrosis. They must show evidence of allergic sensitization, either via a positive skin prick test to Aspergillosis or elevated specific IgE antibodies in the serum.
Furthermore, their total serum IgE level must be massively elevated, strictly defined as greater than 1,000 international units per milliliter.
Okay, over 1,000.
Right. And to complete the diagnosis, they need at least 2 of 3 supporting criteria. First, elevated specific IgG antibodies or serum precipitins against Aspergillus. Second, a blood eosinophil count greater than 500 cells per microliter. And third, compatible chest imaging showing that characteristic mucoid impaction.
Wait, I have to point out a seeming contradiction here. For invasive aspergillosis, you said the primary goal was to decrease immunosuppression so the body could fight the tissue-destroying fungus. But for ABPA, the primary treatment actually requires prescribing systemic corticosteroids. Why are we suppressing the immune system of someone with a fungal issue?
That's a great question, and it's a huge paradox. But you have to target the primary pathology driving the disease state. In ABPA, the fungus isn't actually invading the blood vessels or destroying the tissue directly.
Right.
The severe destructive Th2 allergic reaction is what's causing the airway inflammation and the bronchiectasis. Systemic corticosteroids are absolutely necessary here to shut down that damaging immune response, halt the eosinophil recruitment, and basically stop the progressive lung damage.
Okay, that makes sense. But to prevent the fungus from proliferating, while the immune system is pharmacologically suppressed, the treatment uses a dual approach. You prescribe the systemic corticosteroids to control the allergy, and you simultaneously prescribe a long course of an oral antifungal, usually itraconazole.
Yes, the itraconazole reduces the overall fungal antigen burden in the airways, which removes the trigger driving the allergic reaction in the first place.
Amazing. Okay, let's pull this entire disease spectrum together to lock it into your memory for test day. When you encounter Aspergillus on a multiple-choice question, your first step is to categorize the host.
Yes, rule number 1.
So 1. Is the patient severely immunocompromised with profound neutropenia? If yes, anticipate invasive pulmonary aspergillosis, angioinvasion leading to the halo and air crescent signs, and aggressive treatment with voriconazoles. 2. Does the patient have intact immunity but pre-existing cavitary lung disease from old TB or COPD? If yes, anticipate an aspergilloma forming a fungus ball. Watch out for hemoptysis from eroding bronchial arteries and manage with embolization or surgical resection.
Exactly.
And 3, does the patient have asthma or cystic fibrosis with refractory wheezing? If yes, anticipate ABPA, massive IgE elevations, those gross brown sputum plugs, and treat with a combination of systemic corticosteroids and itraconazole.
That is the perfect summary. But before we wrap up, there is one final, really rare presentation of Aspergillus that builds on our earlier discussion of environmental exposure.
Oh.
We mentioned several species earlier, but there is another one called Aspergillus clavatus.
Oh, clavatus. Right. This species thrives in germinating barley.
Yes. So if you are presented with a clinical vignette about a patient who works in a brewery or a distillery, constantly turning and mixing germinating barley to make malt, and they present with a fever, cough, and shortness of breath just hours after their shift, you should immediately think of malt worker's lung.
Malt worker's lung.
Right. It's a specific form of hypersensitivity pneumonitis caused by the massive inhalation of Aspergillus clavatus spores in that particular industrial setting. It's an occupational hazard that creates a highly memorable exam question tying environmental exposure directly to pulmonary pathology.
That is super high yield. Oh, and I have one more provocative thought to leave you with. One final rare exam presentation to mull over.
Let's hear it.
If you were aspirating a pleural effusion and the fluid comes out completely black, which specific species of Aspergillus should jump to the very top of your differential?
Ooh, completely black fluid. Well, based on the stains we discussed earlier, Aspergillus niger.
Oh, exactly, Aspergillus niger. Just something to keep in the back of your mind. We strongly encourage you to keep crushing your MCCQE prep. After you finish listening, take a moment to look up the StatPearls images we discussed today.
Yes, visually anchor the acute angle branching of the septate hyphae, the hemorrhagic ground glass of the halo sign, and those branching finger and glove opacities.
Visualizing the radiology connects the underlying cellular mechanisms directly to the macroscopic presentation you will see on the exam. Thanks for joining us on this deep dive.